Hi, this is Terry QT, founder and director of Deep Sea Foundation. Welcome to the educational channel where we discuss topics related to breast reconstruction for those affected by breast cancer. I'm very honored today to welcome my guests, Kim Bowles, and Kim is the founder and president of Not Putting On a Shirt, a nonprofit advocating for optimal flat closure. Welcome, Kim.
Thanks so much, Terry. Thanks for having me.
Oh my gosh. So I'm just going to roll with a little bit of casual conversation here and let the viewers know how we met. And it was really through social media. We chatted, we had a long conversation with each other on the phone. What was it, a year, 2 years ago? I don't know.
Yeah, it was a while back in the day before the coronavirus.
Yes. But, we both have been affected by breast cancer. So, we don't choose that, right? That is an event that happens in our life. So then what do you do after that? What do you do if you're faced with breast surgery? Not all women and men are. They have a breast cancer diagnosis and they can be treated without surgery. But for many, I would say a majority, they are facing some type of breast surgery. Now, that can mean a lumpectomy. It can mean a mastectomy. Either way, there's important questions to ask. And this is where our worlds collide, Kim, and what we have talked about through long conversations. I had deep flat breast reconstruction. I chose reconstruction, but I was also flat for 7 months. There's a huge difference in your story and mine. I had a very difficult time being flat for 7 months, but I want the viewers to know that I knew that I was going to have breast reconstruction. I had solidified that decision in my mind with my breast surgeon. So she did a skin-sparing, nipple-sparing mastectomy. And I had a lot of that, what I would call residual skin, the residual skin envelope left over and remaining, those folds of skin. Mm-hmm. My nipples were folded into the folds of skin. I had a difficult time dealing with that for 7 months. I had a difficult time dealing with it.
Yeah.
My choice was to reconstruct. In the world of breast cancer and plastic surgery, what we have to remember are the options and the respect of decision. The only way that can come about is if we have a shared decision-making conversation with the surgeon who is going to do our surgery, no matter what we choose. So what I'd like for you to do today, Kim, that was my short, long version of how there's really three elements here. There's the functional. How do we go about our daily lives? There is the aesthetic. What's it going to look like? And then we might have to cover this in a whole different video. There's the emotional, the nakedness, the sexuality, the femininity. That is a huge topic. We'll leave that one to the end and see how our time's going, Kim, and maybe we'll tackle that one on another day. Tell me your story and why you are advocating for optimal flat closure.
Sure. Yeah. So I would add to those three categories, I would add financial barriers and disparities in care, because although you and I had, it seems like, really good access to all of our options, I don't think we had to face some of what many women have to face, even though insurance companies are required to cover breast reconstruction. It's still the case that a lot of women aren't even offered it. just like a lot of women aren't offered flat. There's room for improvement on so many fronts. And I don't want to come across as ungrateful for the options that we do have. I mean, we've come a long way. I mean, flap surgery is only, what, 15, 20 years old? I mean, flap surgery has not been around forever. Implant surgery was first, and then the microsurgical techniques. So we're in a position today where we have more choices than we had before. And it's really about, like you said, it's about choice. It's your personal preferences and your values and your priorities. You know, many women faced with the amputation of their breasts, which is what a mastectomy is, it's amputating.
Yep.
They experience that as a very significant loss to their body map or their body image, the way they see themselves and the way they want the world to see them. And so reconstructing their breast mounds can be really important to those women, you know, despite all, you know, any risks involved with reconstruction or any other negatives. It's a matter of priorities. And so priorities are very personal, and that's why there's no single right answer for the reconstruction decision. The important thing is full information about all of your options, access to the specialists that you need to achieve the best quality result, and respect for your decision, space for you to make that decision. And I mean, it should go without saying, your surgeon should carry out your wishes that you agreed on. Should be that's foundational to all medicine. Consent is foundational. So
it didn't happen in your instance, did it?
It didn't. And I have to say, like, this was, gosh, what, 2.5 years ago now? You know, breast cancer is traumatic. You know, you've been there, you've been through it, I've been through it, a lot of your listeners have gone through it. Yeah, It's not something that anyone would ever choose. Right. You know, we're put into a situation where we have to make the best of options that are none of them are perfect. You can't restore a fully functional, fully feeling breast mound at this point. We don't have that technology. So anything we choose is going to be a compromise, you know, a compromise between what we're facing and what the options are. And everyone has to weigh the risks and the benefits. And in my case, I had a very large tumor. I was only 35 years old. It was HER2 positive. I had a strong history of breast cancer. So from an oncologic standpoint, excuse me, I'm going to pull what's his name? What's that guy's name that tried to sneak the water on national TV?
No, sneak all you want.
I forget that guy's name now. What happened for me was, I had all these risk factors for recurrence, and the tumor was very large and it was close to the chest wall. So it ended up being the case that a lumpectomy was not on the table for me, even after neoadjuvant chemo that actually destroyed the whole tumor, but you don't know that until after surgery. So I was looking at a mastectomy, and we decided it was going to be a double because of my family history and other reasons. And at that point, my decision was made for me. I never considered implants because the idea of the end result of implant reconstruction was not something that appealed to me at all. I don't want to disparage implant reconstructions. It's hard, you know, it's hard when we talk about these things. I mean, I have reasons why I made that decision, but other women made the decision to go with implant reconstruction, and they're very happy with it.
You know, Kimberly, Kim, we're going with Kim.
You there on the other side of the camera.
Here's the thing. I was the same way. The morning my surgeon told me about all my options, she sent home implant information. But for me, the earmuffs went on when she mentioned deep flap. And I know so many women who have had successful implant reconstruction, and you know, the shelf life of an implant is 10 years. That's manufacturing shelf life. I know women who have had them in much longer, have not had any problems, and they're very happy with them. Again, this is all about personal choice and knowing your options. You said it so well earlier.
It is, and that's why advocates for reconstruction are natural allies with advocates for aesthetic flat closure, because it's not about one being better than the other. It's about women having full information and being able to access the optimal aesthetic result, you know, that is going to make them as comfortable with their new body as they can be, and just move on with your life, heal and move on with your life. And when you look in the mirror, you should see your choice reflected back to you. You shouldn't see a violation of your consent, which is what happened to me. I woke up and my surgeon, who I had hired, a plastic surgeon, to do the flat closure, that was his only job, flat closure. He decided to leave me, you know, the mastectomy pocket skin for future implant reconstruction. And that was directly against my consent. So when I woke up and looked in the mirror, I saw a violation of my consent. And that there's many reasons why women receive suboptimal flat closures.
Mm-hmm.
But in my case, it was intentional, and that should never happen. There should never be a single instance of intentional violation of a patient's consent. Never.
You know, when I listen to you, what I'm hearing you say, and from a patient perspective, it was as if, I mean, you and I respect each other's decision for breast surgery, but I'm almost hearing you say that your surgeon didn't respect that, because that surgeon was projecting what they thought you wanted,
Yeah.
perhaps in the future, leaving all of that skin for possible reconstruction, when you had clearly stated, and you took ownership of that decision.
Yeah. You make peace with your decision, right? I mean, when you go into surgery, I'm sure you had the same experience. You go into surgery, you've made peace with, you don't know exactly what you're going to look like waking up, but you've made peace with that final decision. It's not easy to make these decisions. We're talking about amputation, and we're talking about permanent or semi-permanent changes to our body. It's not easy to make these decisions. It's very important in terms of your well-being and your health moving forward, not only your physical health, but your mental health, that you feel that you can trust your providers. And most of the time, that absolutely is not even in question.
Mm-hmm.
You know, what happened to me was unusual. By my data, it's like 1 in 20 women are intentionally denied a flat closure. That's women that choose to go flat. And there may be a bias to that data. That's not, you know, that's not a large scale, you know, professional study. That's just a pilot study. So, but I mean, that's enough. I'm not the only one that's happened to, and it's enough to justify the work that I and the rest of my organization and our volunteer force is doing now, and other advocates for flat closure. It justifies it, you know. So there's more than one component to the advocacy. What happened to me was egregious, and most of the time when you get a sort of a bad flat closure, it wasn't intentional.
Yeah, I think that
Hard to talk about.
I know it is, Kim. And you know, so you said something a minute ago about you come to peace with your decision. I've had to make, not in my reconstructive journey, but in my treatment journey, I've had to make some tough decisions about whether to have chemotherapy or not, to be honest with you. And I got some pushback from the medical community. And you have to get the information, you have to get the data, just like you did in your instance. But once you come to peace of mind with that decision, and you know that you're going to live with that decision the rest of your life, you know when you have peace of mind, and you know you can move forward. And so that's the element of respect that I think we have to have for each other in our own communities, but also the medical community for us. What I'm thinking of some questions here, Kim.
Sure.
What would you want to tell women and men who are facing a mastectomy, who now have to consider breast surgery, and they're like, you know, I don't want to do reconstruction. I don't
Yeah.
want to have reconstruction, but I know there's questions I should be asking. What are those flat closure? What are those, optimal flat closure? I love that word, optimal flat closure questions. Expand on that a little bit for us.
Yeah, so optimal flat closure comes from the Oncoplastic Breast Consortium, which is an international organization that promotes oncoplasty, and that includes nipple-sparing mastectomy with immediate implant reconstruction and oncoplastic lumpectomy. And now, since the beginning of this year, it includes optimal flat closure as well. So optimal flat closure came from them. Just want to say that. And the term is
Yeah,
yeah. I
you
was
and I,
so happy to see that.
I am too, and you and I know who some of those powerhouses are in the oncoplastic world. So kudos to them. We're all starting to kind of come together on this, and I love that.
Yeah, absolutely. So the question you're asking is, if you've decided to go flat, like what are your next steps to make sure that your choice is respected, or what should you be thinking about in terms of your aesthetic result? That's a great question. You should know that most people who choose to go flat are happy with their flat closure.
Mm-hmm.
It's not a scary situation where, oh my God, somebody's going to disrespect me. That's unlikely. So just, it's probably going to be okay. And you can maximize your chances of getting a great result by taking a few simple steps. So the first thing is to be very clear with your surgeon at what your decision is. Now, we're assuming that you have, in fact, made your decision. A lot of people are sort of like still on the fence for a long time. And I'm not talking about those people. I'm talking about people that have made their decision, that have come to terms with it and are their final decision. So, and that's a lot of people that go flat, honestly. A lot of people are just like instantly, I don't want reconstruction.
Mm-hmm.
That's the case for a lot of people. And it's okay if you're still undecided. That's okay too. Your process is your process.
Right.
But what you should be figuring out is does my surgeon respect my choice?
Mm-hmm.
And are they committed? Are they able? And are they committed to giving me the optimal result at my initial surgery?
So we have scar considerations and the residual skin considerations. Talk to us about that and some questions to ask.
Yeah, so we're talking about a simple mastectomy here. So the breast tissue, if you imagine a breast, like a large natural breast, okay, the breast tissue itself, the glandular tissue and the duct tissue is like, I don't want to oversimplify, but it's almost like a tennis ball that's like lodged in the middle of that. Mm-hmm. And everything around it, all the other contour tissue, that's all fat and skin. Mm-hmm. So the mastectomy from an oncologic standpoint is intended to remove the cancer-prone tissue, which is the glandular tissue. Mm-hmm. It's that tennis ball. If you just scoop out a tennis ball from a breast and then you sew it up, you can imagine that looks pretty hairy. It's not going to be smooth. It's not going to be flat unless you're one of those women with extremely small breasts and very low body fat. Mm-hmm. So for a woman with very little body fat or very small breasts, it's pretty simple, and you have a really good chance of getting a great result even if you don't take any additional steps. Mm-hmm. For women that are larger bodied or with very large breasts, it's managing that tissue surgically. So, managing, that's removing the tissue and or rearranging it so that it is a nice, smooth, flat result. The more tissue you have to manage, the more skill required and the more time required that your surgeon is going to need to invest. And you can make sure that your surgeon is willing and able to do that. And by willing, I mean, when you say you want to go flat, do they say, oh, that's not, women can't be flat, or your husband's not gonna like that. If they react in any way other than, great, let's do it, that's a red flag. And you should consider a second opinion if you can, because most surgeons will respect your decision. And if you land on one that doesn't, that's not somebody I would want to trust with my body, and my decision.
It's the same as if you're going in for reconstruction and you say you want autologous tissue and they go, oh, you don't want to do that. That's too tough. You should really do implants. It's the same thing.
Exactly. And it's a really good analogy, because For a DIEP flap, for example, that's a microvascular surgery. That requires specialized plastics training beyond your standard training. Not all surgeons can offer that technique. If you land on a surgeon that doesn't have the training, they would have to refer you in order for you to get that reconstructive choice. Right. Most will refer you. Some might just not even mention it. They might just put implant reconstruction as the only, real option or the only reasonable option. So it's important to know what the skill set of your surgeon is and does it match what you want.
You bring up the point about your surgeon's skill, Kimberly, and what I want to circle back to is a comment you made about the different types of, you referred to a woman who is very low BMI and then women who have a higher BMI. So the reality of it is, I believe, from what I've read and understand, is that flat closure doesn't always mean one surgery.
Correct. So I was actually talking to, God, who was I talking to about this? I was talking to a guy that's in charge of breast surgical oncology at a major medical center just yesterday, which was an amazing conversation. I look forward to moving on all those things we talked about. One of his concerns with sort of advocating for aesthetic flat closure is that he doesn't want patients to have unreasonable expectations about that. He was saying, for a patient that's very obese, that just means more tissue. It's not a judgment at all. It's just a physical reality that the surgeon is dealing with more tissue, and maybe more tissue that might not have a great blood supply because fat doesn't have a super great blood supply. There are constraints presented by a lot more tissue, and it's true. And you that's why if you are one of these patients that faces these challenges, you might need a plastic surgeon. And even with a plastic surgeon there at the initial surgery, there may be some settling of the tissues where you might need a revision surgery, like a minor revision surgery. And that's okay as long as the provider is upfront with the patient about that, properly setting the expectations. I think based on my conversations with lots of different surgeons, that most women going flat can get a reasonable result in one surgery. Most, not all.
Yes. But so yay for us being able to bring this up today, that sometimes it's not. Sometimes you have to have a revision, a smaller surgery to get the final aesthetic outcome for optimal flat closure.
It's true. But most patients going flat, one of the main reasons they make that choice is they want to be done with surgery. Yeah. So you have to balance, your breast surgeon, your surgical oncologist can probably get you 80-90% of the way. And for many women, that'll be good enough. The question of what is good enough, you can always have one more little surgery to revise your breast reconstruction or your flat closure. I mean, there's almost never going to be a point where it's perfect. The question is, how do we balance the patient's desire to have as little surgery as possible with also desiring an optimal aesthetic result? And that's why shared decision making is so important as a model of clinical practice and decision making, because that balance is going to be slightly different for different patients.
It is.
And that's okay. It's easy to anticipate that fact, and only by a collaborative discussion can the patient and provider come to the optimal course of action, that serves the patient's needs.
And I don't know about you, Kim, but I feel like that's part of my job, our job as advocates, to provide the vocabulary, to provide the information and education so that women can go in and have this shared decision-making conversation. Because, to be honest, there are those who want to be fully engaged in the conversation. You have children, I have children. We know that sometimes children are very vocal and verbal, other children are quiet and observing. It's not any different with patients. But if they don't have the information and vocabulary to engage in it, no matter what form that takes on that spectrum of shared
Yeah.
decision making, then they can't be a part of it. And so I think you brought up
I
some.
was just reading this textbook because I'm a nerd. It's called Surgical Ethics. There's a lot of discussion in here about the ins and outs of shared decision making implementation of shared decision making, because it sort of sounds like a soundbite, but then actually implementing it with your real life patients, that there's such a huge variety of their level of capacity to understand their different options, how they're receiving the information, what their medical situation is, their cancer situation. I mean, we're not talking about an elective surgery here. It's complicated. And there's been a lot of discussion among providers about how best to implement that. And it's important that this discussion be evidence-based. And that's why the research on patient-reported outcomes is so critical. And we've seen a lot of great research come out in the last 5 years or so. Clara Lee, in particular, has done a lot of really great research on like decisional regret and patient-reported outcomes. It's just, I don't want to give the impression that this is something that patients are on about, but providers are not. It's not true. They're really, this is a serious like paradigm shift in decision-making in clinical practice, going from sort of the historic paternalistic surgeon tells you what the best option is and you say yes or no, versus the collaborative process that actually results in better outcomes. It does. And seeing the evidence of the benefit of shared decision making is so important. This is not a theoretical thing. This is something that improves outcomes for patients.
Studies have shown it.
Yep, and they continue to show. And in our work for promoting aesthetic flat closure, we're working on that also. We're working on potentially trying to build a scoring tool that's like an objective measure of the aesthetic quality of a flat closure, just like you have for implant reconstruction and for flap reconstruction. It's important to have the foundation, the evidence-based foundation for how to proceed. And a lot of what we're doing is just trying to build that foundation. And the first part of it was this aesthetic flat closure term that the National Cancer Institute adopted earlier this year. That is, huge. I can't overstate the importance of that.
It's huge.
Clear language. It is absolutely huge. Absolutely. Because not only can patients now ask for a specific, defined, shared understanding of what it means, there's no ambiguity anymore. If patients know the term, right? And not all providers even know the term yet because it was so new. And that's a huge part of our work right now is awareness about aesthetic flat closure. It's just
education and awareness. It's really
education and awareness, and building a coalition of stakeholders, because almost all surgeons are in it because they want to help people and they want patients to have optimal outcomes. It's just a question of like working together to get there. Starting from where we're at, what needs to happen to get there. And I've seen a lot of great work. Results have happened so far this year, and I'm hoping that this year we're going to see even more in terms of moving the needle for considering flat closure to be an aesthetic procedure, that you should have a plastic surgeon if that's what you need. If you have a larger body and you need a plastic surgeon to do that work, you should be able to access that just like someone who wants implants or someone who wants a deep flap. You should be able to access it, and you shouldn't have to take extraordinary measures to be able to access it.
Well, let's keep working on that. Let's keep working on that together, because, in the shared decision-making model, and also all of the complexities of a breast cancer diagnosis, whether you've been diagnosed or you're at high risk, there's a lot of emotional complexities with that. There's a lot of things that plastic surgeons have to deal with. I call it the canvas. All body habitus are different, and scarring issues, residual skin, skin laxity. There's so much involved in this, Kim. Let's keep the conversation going. Let's have another discussion about this. Today, I'm just so grateful that I finally got to sit down with you and have
Me
this.
too, Terry. And I will talk about this anytime. Anytime.
Yes, yes. And I think, we can dive a little bit deeper into some other things that go along with the decision-making process in any type of breast surgery that you have. Keep doing what you're doing. We know where to find each other. We'll be continuing the discussion. What I would like for the viewers to do today is to comment on this. I have women on my Facebook group that is for breast reconstruction are asking me, I may want to go flat. We've got to keep this conversation going. So please comment, ask any questions on the video that will be produced today. We'll have Kim's information about her organization, and let us know if there's other topics we can cover. And thanks for joining us today, Kim. It was great seeing you.
Really good to talk to you today, Terry. Thanks so much.
Yeah, stay safe.
You too.
Take care.